So the last manual physiotherapy technique that we're going to come on to is shakes. This is a technique where the therapist would add a large amplitude compression throughout the expiration phase to aid mobilization of large volumes of sputum and to help generate a cough because of the large amounts of pressures that are being created inside the lungs. You'd normally use this inside lying again, and it generates large amounts of turbulence and it aids sputum mobilization centrally. So you're applying the large amplitude oscillations between 3 or 4 generally throughout the expiration cycle, and you'd use it in a patient who's got persistent secretion retention where manual assistance for coughing may be required, and it's helped by the cough is helped by the increase in pressure that's created by the shake. Side effects of this technique can be that if you use too much pressure to compress the lungs, you take the patient past their functional residual capacity and you're taking them into their closing volume, so you actually causing airway closure, which is what we don't want to do. Also, because of you're raising the intrathoracic pressure with the compression, you're decreasing the patient's blood pressure, which can decrease venous return, thereby decreasing stroke volume and reducing cardiac output. Specific contraindications are the same as VIBS with osteoporosis. Pre-existing bronchomalacia is one that you should not use shakes with because it can aid small airway closure. Also, patients who've had skin grafts, the shearing forces created and the pressure that you use with this technique can disrupt the skin graft and the blood supply to it. So here we have a demonstration treatment of a shake. What again you do is you get the patient into side lying. This allows you access to the lateral lungs. Get your hand position again in that butterfly, and you'd want your hands on the lateral aspect of the chest wall. In female patients, you'd be careful not to be putting your hand too far around the front. Also, you really don't want to be up into the axilla because that might be uncomfortable for the patient. What the patient's going to do is take a nice slow deep breath in. On the out breath, you're going to apply a compression force down into exhalation. However, you want to watch how far you're going down into exhalation and once you finish breathing, because you don't want to be causing that decrease of the functional residual capacity to meet the closing volumes, because then you'll be causing airway closure. So Liz, if you can take a nice deep breath in for me, and out, and again, out. Once more. Okay. So you do this technique between 4 and 6 times, intersperse it with the forced exposure technique and coughs to aid sputum clearance and get the patient getting rid of the respiratory secretions. It would be really useful in patients that struggle to generate a strong cough, so that they struggle to clear any areas of sort of basilar secretions, because you're helping it to move towards the main bronchus.